Sir, it's already 4. With all your permission, I'm starting this session. We are live now. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Abhyuday Verma, sir. Sir is an associate professor at the Department of Endocrinology, Index Medical College and Research Institute, Indore, Madhya Pradesh, and ex-professor of medicine, UG and PG guide and examiner. Today, sir is going to discuss on a topic management of diabetic neuropathy. Nephropathy. Let me tell you overview of the topic. It is one of the most complex complication which is found nowadays in every age adult. By taking not much time for more details about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Mr. Faraz, for the kind introduction. And dear friends, as we all know that there is a pandemic of diabetes all across the globe. We are striving hard to control the blood sugar levels. But we know there are a lot of still unseen, untreated complications of diabetes which increase the morbidity and mortality of our patients. And amongst these complications, today I would be talking about diabetic nephropathy. Because see friends, we keep talking about the cardiovascular disease, stroke, but latest data have shown that lot of diabetic populations, especially Asians, or I would say Indians, are more susceptible to complications like cardiovascular disease and nephropathy. A lot of our diabetic patients, they go undiagnosed, or sometimes they present directly to us with a full-blown nephropathy. So today I would be talking very briefly, maybe like just a general overview that what is diabetic nephropathy, what we can do to diagnose it early, and how we can stop its progression or make our patient get rid of this nephropathy. So first I would say there were some older terminologies which are not being used nowadays, just to not talk about those things in front of our patients. Like we now say kidney disease, not a renal disease. We now say CKD, chronic kidney disease, not a chronic renal failure, which looks very depressing to our patients. DKD, or diabetic kidney disease, or diabetic nephropathy, not acute renal failure. We say acute kidney injury, but end-stage renal disease and renal replacement therapies we still use. We couldn't find out any simpler words, but yes, end-stage definitely needs that the patient should be also aware of this. Now, what is the diabetic kidney disease or a chronic kidney disease? When the structural or functional abnormalities of kidneys are present, for more than or equal to 3 months. And these can manifest as either a kidney damage with or without decreased glomerular filtration rate or GFR as defined by pathology abnormalities or markers of kidney disease, including abnormalities in the composition of blood or urine or abnormalities in the imaging tests of kidneys, or a GFR less than 60 ml per minute body square with or without kidney damage. So these are some of the definitions how we can label our patients as having chronic kidney disease. And here, this is a slight old data, but still holds good, that 40% of new cases of end-stage renal disease are attributable to diabetes. And in 2001, about 41,000 patients with diabetes began treatment with end-stage renal disease, and the cost was quite high. Especially, these are data from the Caucasian countries. So they say minorities experience higher than average rates of nephropathy and kidney disease. And we'll see which are these patients who are at high risk of developing diabetic nephropathy. And here you can see these are incidences of end-stage renal disease resulting from primary diseases. You can see here diabetes and hypertension scores almost 2/3 of our patients. Rest are glomerular nephropathies, nephritis, cystic kidney, and other disease of end-stage renal disease. So what happens here? In a chronic kidney disease, there is a progressive increase in the urinary albumin excretion, UAE. So we can see here that there is a proteinuria along with increase in blood pressure and then a gradual decline in the GFR. If we talk about diabetic patients, in type 1 diabetic patients, 35 to 50% of these type 1 diabetic patients suffer from the diabetic kidney disease after 20 years of disease. And it can be earlier if the blood sugar levels are not well controlled. And 10 to 20% may have diabetic nephropathy at the time of diagnosis of type 2 itself. Why? Because type 1, most of the time, we know that when it started, but type 2 diabetes, if we go to the pathophysiology, then the type 2 diabetes problem with impaired glucose tolerance, impaired fasting, has started years before the diagnosis, which can increase the chances of various complications even before the diagnosis of full-blown type 2 diabetes. And renal risk is equal in both type 1 and type 2 diabetes. It basically sees that how the blood sugar levels and the comorbidities are controlled. And progressive rise is seen once the patient develops this albuminuria, reduction in GFR. And almost 40% of the patients on renal replacement therapies are due to diabetic nephropathy. And this diabetic nephropathy has got a strong association with cardiovascular disease, up to 20 to 40-fold higher. So high risk. If somebody develops a diabetic kidney disease, then that patient is very likely to develop a cardiovascular disease also. So now, before going to talk more on diabetic nephropathy, we should understand the stages of this CKD. And nowadays we used eGFR or estimated GFR for CKD staging. We don't use serum creatine nowadays much. Stage 1, GFR is more than or equal to 90. There is a mild kidney damage and increase in GFR. Sometimes you may see GFR more than 100, 110 also. Stage 2, the kidney damage is mild. And here, from here, you can see there is a reduction in GFR, 60 to 89. Stage 3, moderate. Further dip in GFR, 30 to 59. Severe, 15 to 29. And kidney failure, less than 15 ml per minute. So these are stages of chronic kidney disease. And if we talk, this stage 1 is the stage of hyperfiltration. Stage 2 is stage of clinical latency. Stage 3 is known as incipient nephropathy. 4, overt nephropathy, and 5 is renal failure. And according to EGFR also, we have seen that how the staging goes with the reduction in EGFR. So here, this is again the same thing, a picturization to understand hyperfiltration, clinical latency, microalbuminuria, macro, and renal failure. And here, microalbuminuria is albuminuria less than 30 mg per day. Macro is more than 300 mg per day. And now we use newer terminologies. So we don't say microalbuminuria, we say high albuminuria, and for macroalbuminuria we say very high albuminuria. So these are some of the newer terminologies, but the things are same. And here you can see, as I said, type 1 we know that when it started, and with the high sugar levels, how this progresses. And here in type 1 you can see normal albuminuria, but over the time with hyperglycemia we get stage of hyperfiltration, microalbuminuria, and macroalbuminuria, or very high albuminuria. This may develop anywhere between 15 to 20 years or earlier in patients who have uncontrolled blood sugar levels. Then there is a stage of renal failure or azotemia. Next 4 to 5 years, and then end-stage renal disease. Progression is very fast, less than 1 year. So these are just for the understanding that how, what is diabetic nephropathy and what are the stages. And we should try to screen our patients as early as possible, maybe at a stage of the stage of hyperfiltration itself, or maybe at microalbuminuria, where at these stages we can reverse and bring the patient to stage of normal albuminuria. And this is same, a mixture of whatever we have talked about: early nephropathy, microalbuminuria, and rising blood pressure, where, as I said, there is an increase in GFR, microalbuminuria, which is reversible, slightly increased kidney size. But then, if we don't take care, we may have structural changes like increase in glomerular basement membrane thickness, mesangial expansion, the onset of proteinuria, increase in serum creatinine, and end-stage renal disease. So again, same micro, macro, and renal failure. And this is the graph. Here you can see the definitions of abnormalities in albumin excretion. Here you can see very nicely the normal spot collection less than 30 microgram per mg of creatinine. 24-hour collection, again less than 30 mg per 24 hours. Time collections less than 20 microgram per minute. Microalbuminuria is 32-299, 24 hours, again 32-299. Clinical albuminuria is more than 300 at spot and 24-hour collection, microgram per mg or mg per 24-hour respectively. And since we know there are a lot of factors which have shown to affect the urinary albumin excretion, there is a lot of variability. 2 or 3 samples should be interpreted within a span of 3 to 6 months before labeling it as abnormal. And what are the factors which affect the albuminuria? Vigorous exercise within 24 hours, infection, any infection, including a urinary tract infection also, fever, congestive heart failure, marked hyperglycemia, marked hypertension, pyuria, hematuria may elevate urinary albumin excretion over baseline value. So these should be taken care while collecting the urine sample for the albuminuria, and then we can label it as micro or a clinical albuminuria, and definitely 2 of the 3 samples should be positive within a span of 3 to 6 months. And here again, not much of clinical significance, but they say we have differences in male, female also, but they are not that important. Albumin to creatinine ratio less than 3.5 in female, less than 2.5 in males. Equivalent albumin excretion is same. Again, for microalbuminuria, male, female, more than 3.5 and males more than 2.5. But the albumin excretion per day is same, 30 to 300. And as I said, based on 2 out of 3 urine sample in absence of UTI, after 5 years of diagnosis of type 1 diabetes, we should start. Don't wait for 10-15 years, as I shown in the progression of type 1 diabetes. So it was just a model, but routinely after 5 years, and then annually we should keep on doing it. And definitely at the time of diagnosis in type 2 diabetes. So type 2 diabetes, again, I would re-emphasize that don't wait for the clinical signs and symptoms or complaint of the patient. At diagnosis itself, we should screen for most of the comorbidities and complications. So here, again, same thing, urinary albumin at diagnosis type 2. If it is negative, then repeat it after a couple of months. If it is positive, it is nephropathy. We should quantify the microalbuminuria creatinine ratio, and if required, consider a referral to a specialist. And out of 3, 2 samples are negative, then we screen the patient yearly. And if there is a microalbuminuria, then we begin the treatment before referring the issues. As I said, that diabetic nephropathy is associated with a lot of complications. Here you can see our diabetic patients with nephropathy. They die not from the renal disease, they die because of stroke, myocardial infarction, heart failure, and sudden death. That's why treating nephropathy is not only important to save the kidneys, but to save the patient's life and morbidities due to these complications also. So what are the risk factors which are non-modifiable, which we may have no control. Indo-Asians, Africans, Hispanics, and Native Americans, they are at high risk of developing diabetic nephropathy, familial clustering in type 1 diabetes. First degree relative, they have more than 80% chances. In type 2, no parent, 14% risk, one parent, 23% risk, two parents with diabetes, 46% risk of developing diabetic nephropathy. Various genetic influences like age, gene polymorphism, angiotensin 2 type 2 receptor gene on X chromosome, inheritance of one allele of aldose reductase gene, low birth weight, age. If type 1 onset is less than 5 years, the risk of ASRD increases. And elevated prorenin levels. So these are some of the non-modifiable risk factors. Modifiable, which we can help our patients, are hypertension control, lipid control, smoking cessation, good glycemic control, reduction in obesity, less use of oral contraceptives, and increased protein intake. What is the natural history? In our routine type 2 diabetic patients, what we see, sometimes we may miss the hyperfiltration state, but if we see a hyperfiltration state or increase in the kidney size, we should get our antennas up and start at least taking care of these modifiable risk factors. Why? Because GFR declines once the proteinuria is present, and the decline is to the tune of 12 ml per minute per year if it is left untreated. And patients die not because of end-stage renal failure, but they die of CVS complications. CVS complications rise to 2 to 3 folds with microalbuminuria and 9 to 10 folds with clinical proteinuria. So it is very important to diagnose them at stage of microalbuminuria or even earlier also. So we have to take care of the modifiable risk factors. Reduce the blood pressure to less than 140/90, because 50 to 60% of the newly diagnosed patients with diabetes already have hypertension, and a family history in a child with type 1 diabetes increases the risk of developing nephropathy. And same is with type 2 also. One parent, two parent with diabetes increases the risk of diabetic nephropathy. Cholesterol levels, try to maintain HDL above 35 in males, 40 in females. Triglycerides, keep it less than 150. And in diabetes or hypothyroidism, we have to take care of lipid profile. In patient with normoalbuminuria, we should take care of blood pressure and blood sugar. In established diabetic nephropathy, we have to take care of hypertension and extra care along with degree of proteinuria. And if required, we can go for renal biopsy to see the mesangial expansion and the tubulointerstitial lesions. And pathogenesis, I won't go in detail, but we know hyperglycemia, early stage, reversible with normoglycemia. Hypertension, if it starts first time in a diabetic patient, it predicts that the patient has started microalbuminuria, and we should try to control both blood sugar and blood pressure effectively so that we can halt the reduction in the eGFR. And proteinuria, When we see a clinical proteinuria, there is already a tubulointerstitial damage. And we should be very aggressive in taking care of our blood pressure, blood sugar, cholesterol, and other problems of diabetic nephropathy also. So this I won't go in detail, but here this is the whole flow chart, how we can see running from kidney, the angiotensin converting enzyme, and the treatment like renin inhibitor can reduce the chances of the progression from micro to macroalbuminuria. Then we have ACE inhibitors. Then we have ARBs, where they take care of various enzymes, the angiotensin 1, angiotensin 2, and receptors, so that there is a reduction in aldosterone secretion, reduction in the cellular growth, improvement in the vasoconstriction, reduced sympathetic stimulation, and there is a improvement in the overall kidney function and reduction of the proteinuria. So we have renin inhibitors, ACE inhibitors, and angiotensin 2 receptor blockers. And here I won't go in detail. We know what the AT1 receptors do and AT2 receptors do. Then we have a crosstalk between insulin and angiotensin 2 also. Angiotensin 2 reduces the insulin sensitivity and insulin secretion, which explains the anti-diabetogenic effect of RAS blockade. And the hyperinsulinemia enhances the angiotensin 2 induced transcriptional activity in vascular smooth muscle. So when we take care of this angiotensin 2 receptor blockage, we take care of the processes also, including the insulin secretion and sensitivity. So coming to the treatment is very simple. Good glycemic control and blood pressure control from day one. Don't wait for the things to progress, and then at later stage, definitely they would be helpful, but try to give a good sugar and BP control from the beginning itself, so that a patient doesn't land up in any stage of nephropathy. Then angiotensin 2 control by ARBs, proteinuria control, and cholesterol control. These are some of the studies. I won't go in detail. We have DCCT landmark study, which showed that even a single % reduction in HbA1c can reduce retinopathy, microalbuminuria, clinical nephropathy, and neuropathy significantly compared to the conventional group. And in a longer term also, you can see after 17 years, there can be a 50% reduction in macrovascular complications also. And this is same conventional versus intensive. Here you can see that strict glycemic control prevents microalbuminuria in these patients. UKPDS done in type 2 diabetic patients. Again, it shows each % decrease in HbA1c decreases microvascular complications by 35 years, and macrovascular benefit can be seen after 10 years of intensive sugar control, and strict BP control reduces the microvascular complications. So what the UKP study told us, that a good glycemic control is less than the benefit from the blood pressure control. So it is basically both. If we take care of blood pressure, there is delay in the development of albumin excretion, stabilization or reduction in protein excretion. There is slow progression of renal injury, even in the stage of macroalbuminuria. And sometimes if we take care, there may be a reversal of early structural changes also. So we have to be very aggressive. So whether ACE inhibitor or ARBs are good, yes, we know that both are good, but what about if we use both together? A lot of studies are there. I won't go in detail. We have studies with the MRAs also, which have shown to slow down the renal injury and proteinuria. Study, it used both candesartan and lisinopril ACE inhibitor. Combination showed good results, but then follow-up is important, and the problem of hyperkalemia is there. Calcium channel blockers have also shown, like verapamil, reduce proteinuria independent of BP changes. Aldosterone antagonists like spironolactone also reduce the proteinuria in diabetic patients. And it should be started in patients in whom ACE ARBs are already there and you don't get reduction in blood pressure or the microalbuminuria. So here ARBs, especially in type 2 diabetic, have shown to have a lot of benefits. They don't only reduce the blood pressure or the incidence of stroke or heart failure, they reduce the renal dysfunction, improve the glycemic control, and chances of cardiovascular problems also. And this was shown in this again landmark study on target, which shows patients at high risk of cardiovascular events but without heart failure were randomized to either telmisartan, ramipril, or combination, and patients were followed up for 56 months, and which showed that telmisartan was non-inferior, and a combination of both was not superior to only ramipril. And in fact, there were few complications with the combination. So they said we can use either ramipril or telmisartan. Both have got equal efficacy, and the combination has not shown any extra added benefit. There are more side effects. So, summary of RAN inhibition, it decreases the risk of progression from normo to microalbuminuria to overt nephropathy, and even from overt nephropathy to end-stage renal disease. And ACE inhibitors and ARBs are comparable. And if GFR drops by 10% after starting these ACE inhibitor or ARBs, it is normally expected. Don't panic, because it will again plateau down and maybe start improving. And a sequential therapy is effective in reducing the proteinuria. And we can see, as I said, ACE inhibitor or ARBs, then we can use MRAs also and other recently available drugs also, but it should be sequential. And don't start immediately. Wait for some time and keep on adding the drug if the response is not achieved. Renin inhibitors, I was talking to you about, plus ARBs and ACE inhibitors, we have aliskiren, but here the trial was stopped because there was no apparent benefit, and in fact there was increase in adverse event. So our ultimate treatment, blood pressure, glucose, proteinuria, and now we come to cholesterol. And again, studies have shown here that good cholesterol control again gives us benefit. Then few words about low protein, yes, but not very low protein. 0.6 to 0.8 grams per kg can be given to our diabetic nephro patient. And obviously, anemia correction is also important to reduce the cardiovascular and renal disease in our diabetic patients, because they have a vicious cycle. CKD leading to anemia, anemia leading to cardiovascular disease, and then the vicious cycle goes. I won't go in details of dialysis and renal transplant. So these are our parameters: lower BP, block RAS, improve glycemia, lower the LDL levels, anemia management, endothelial protection, and smoking cessation. These are the usual points of management to take care of diabetic nephropathy, reversal or management. So diabetic nephropathy is the most common cause of ESRD, and ESRD is a rare outcome among diabetes. Over half of our diabetic patients will develop nephropathy. So this is so important. Start taking care from beginning by good blood pressure control, good sugar control, ACE or ARB ARBs and proteinuria reduction. Screening from the diagnosis of type 2 diabetes and then annually. Good glycemic control. Once microalbuminuria starts, immediately start a RAS blockade. BP target obviously should be individualized according to the patient's comorbidities and age. And our treatment initially should be to stabilize EGFR and reduce the microalbuminuria. Take care of other vascular risk factors also. And if renal replacement is necessary, don't wait. It should be planned in advance and refer to the super specialist as and when required. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice. Sir, we have received some questions. Shall we take with all your permission?
Yes, please go ahead. Please carry on. Yes. Mr. Faraz, please carry on.
Sir, can you hear me?
Yes, please carry on.
Yes, sir. The first question is, which immunofluorescence microscopy findings are characteristics of diabetic nephropathy?
See, as I have shown in my slides also, the tuberointerstitial damage, then we may see the podocyte gaps also increase the damage to the podocytes. Then we may have efferent and efferent arterioles, the increased glomerular pressure. These are some of the changes which we see in diabetic nephropathy. But as I showed that these are not that much required. Small things like increase in the proteinuria and the blood pressure can guide us that the things have started developing.
Okay, thank you so much, sir, for answering it, sir. I can see few more questions, sir. I will be taking next question. The question is, what is the role of glycemic control in the etiology of diabetic nephropathy?
Yeah, very true. But see, basically, I would say that this all starts with the chronic hyperglycemia. And chronic hyperglycemia, we know there are a lot of pathways, the advanced glycation and products, the sorbitol pathway, the oxidation, etc., which puts not only the kidneys but all our vital organs at risk of developing complications. So definitely hyperglycemia is the most important thing in all our diabetic patients to reduce various complications.
Thank you so much, sir, for answering it, sir. I hope that the participant who have asked has received his answer. Moving forward, I can see couple of question is there, sir. We will be taking last two questions. Are predictors of morbidity and mortality of diabetic nephropathy?
I think the rapid deterioration of kidney functions, um, vascular problems, uh, we may get the cardiovascular problems, heart failure in our patients. So these are some of the predictors. Maybe even like the retinopathy also should be screened in our patients, because this is one of the earliest vascular changes we can see in our diabetic nephropathy. So it's basically we have to keep a close follow-up of our diabetic nephropathy patients, especially for the vascular changes. And if we see a slight vascular change also, then we should be very strict about the blood pressure, sugar, cholesterol control.
Thank you so much, sir, once again explaining it really well, sir. We will be taking last question. And the question is, what is the frequency of end-stage renal disease, that is ESRD, in patient with diabetic nephropathy?
I think, see, it all depends on which setup the patient comes. If we see somebody in a tertiary care center, then we may see high number of cases. But I would say yes, the end stage renal disease patients, where the doctors are treating them well, they are taking care of other comorbidities other than just the hyperglycemia, the chances of ESRD are reducing. But then we know a lot of our patients, they present sometimes to us with a end stage renal disease or stage 4 of the DKD. So it is at least, to my knowledge, maybe good kidney centers, they may be able to tell you. But as far as my knowledge, I believe that if we start screening patients early, we can stop a lot of our patients going to end stage renal disease.
Okay, thank you so much, sir, for answering all the questions, sir. We are very glad to have you on our platform. As there is no more question from the participant end, shall we conclude this session with all your permission?
Thank you, IJCP, and thank you all, dear colleagues.
Okay, thank you so much, sir, and hope to see you again with different topic. Till then, take care of yourself. Have a great